Vijay, or praise him because he has gotten us into something where I think it's the first time we are doing this kind of a thing in a meeting at least. We have 5 students, Dr. Prashant, Dr. Unmesh, Dr. Sridharan, Dr. Karthik and Dr. Atul. If all of you are there, can you come up on the stage? Here. Right, so all 5 of you are there. I can see. Okay. So our examiners are Dr. George. So you can sit there or you want to sit on stage? It's probably better. So our examiners can be seated down. I think Dr. George, of course, all of us know. Dr. Bhavesh is there virtually, I think. Then yes. Dr. Mehul Thakkar is here. Dr. Mehul can be the audience. So can we have the examiners in the center table? Then Dr. Sanjay Sharma, sir. Coming in 5 minutes. Okay, Dr. Naveen is on virtual. Is Dr. Naveen there on the virtual? Yes. Okay. And Dr. Sagar, he's there here. Yeah. So Dr. Sagar, if you can just come to the center table. So the students can be on the stage, whoever is presenting. How many? 1? So how many have come of the students? 5 of you? We have 1, 2. Okay, so what I'll do is, I think this is, like I said, the first time we are doing it. How we will go ahead is the students have prepared a presentation, which we will be going one by one. So they will present the first history and examination, followed by the investigation findings, and then followed by general questioning. What I will follow is just I will call out the examiner one by one, and each examiner can take any student and ask them questions. So a single question followed by a couple of follow-up questions. So each round we will try to make sure that all examiners get to question. We have, I think, 6 examiners and only 3 people I can see here. So like Gabbar Singh said, bahut nainsafi hai, but I think we'll have to live with that for this thing. And after that is done, probably 30 minutes or so, we'll have a general discussion on management of early lung cancer. This is mostly early. We'll go a bit into the advanced as well. So, okay, we have around 1 hour, Nandini. How long? Around 1 hour. Fair enough. So we'll go with this, right? So if you can project the presentation, just 1 minute for that as well. Okay. So in the meantime, if the students can just introduce themselves, because again, if you can just tell your names and which department you are working in.
Hello. So I am Dr. Atul. I am medical oncology SR from PMH Mumbai.
Okay.
I'm Dr. Prashant Naik. I am the radiation oncologist SR at
okay.
PMH.
And your colleague, he's there. Okay. So who will be presenting one of initially cases? You'll be presenting. Okay, great. So I guess Dr. Unmesh has not come, and he's Dr. Unmesh. Okay. So the surgeons have not come. Sridharan and Karthik.
Yeah.
Okay. Okay. So I think Friday OPD is running because of them, or the OT, whatever it is in TMH. Great. So we have the 3 students, and we can start loading it. Then we will start the meeting. And if anyone else wants to ask any questions in between, please feel free. Dr. Govind Babu sir is there, so I'll rely on him to ask a few questions as well when we run out of questions here. Right?
So Vamshi, I am online. I am examiner.
Yeah.
Hello.
Okay, so the 2 surgical residents are also on the way. So let them come. As soon as they come, they'll join you guys. So you'll have more company. And Dr. Sanjay is also on the way. Okay, right. So Dr. Prashant, can you start the case? You can take the mic and start. Then it's okay. Then you can read. Yeah, go ahead.
So the case that we'll be discussing today is a 65-year-old lady. She resides in Mumbai. She presented with on-off fever for 3 months, and she has cough with expectoration, which is a long-standing history. She, at the time of examination, did not have any hemoptysis, no breathlessness, no weight loss, and no pain in any of the bones. She is a known case of hypertension who's on medication for the last 10 years. She has a past history of pulmonary tuberculosis. initially treated 25 years back, after which she had a reactivation 6 years back. She is a known tobacco chewer for the last 35 years, reformed since 3 years, and she has not had any history suggestive of COVID-19 and has been vaccinated for the same.
Right. So, Dr. Mehul, if you can start off, anybody you can ask by name, if you can just call the student and then ask your question and a couple of follow-up questions.
Anything else you would like to know? I mean, it will be general for all of it. This is a very common patient who comes to at least a chest factors, and a patient coming with cough and fever. Any other questions you want to ask them? See, back pain and hip pain is probably something which, as a chest physician, would not be the first thing to ask. What else would you want to do? Anything else?
You can ask him about hoarseness of voice.
Yeah.
And
you go to the next slide, please.
Dr. Atul, if you can add anything.
So weight loss is also important.
Yeah, see, you mentioned hypertension, but there is no mention of any diabetes or anything. An elderly patient with weight loss or with cough and fever, I would also look out for diabetes or any surgical history in the past. Those things for us become very important in the OPD. We would not know this patient is tuberculosis or malignancy.
Any comorbidity, I think.
Yeah,
we
just highlight all the comorbidities, at least the common ones which we expect in such patients.
Yes.
Dr. Sagar, any questions from your side? Okay, you want to go into the exam. Okay, Dr. George, sir, are you there? Is Dr. George there? Online, virtually? Yeah. So, till he joins, Dr. Bhavesh?
Yes, I am already joined.
Yes, sir. So, anything that you would like to ask in the history part of the thing? Imagine this is an exam you're asking students, so you keep doing that day in and day out.
Yes. So I'm perfectly okay whatever the history is presented by Dr. Atul. And at present, the most important part is some negative point also. Negative history is also very important. And I think most of the questions or most of the thing has been covered. So I'm okay with the history part.
Okay. Dr. Naveen, you're there virtually?
Yeah, I'm here.
Yeah, Dr. Naveen. So anything that you would want to ask, any part which has been missed out?
Yeah. So the only question to Prashant here is, so you mentioned about pulmonary TB the patient had and it was reactivated. So I would also want to know whether the patient was adequately treated.
So the patient has been adequately treated, has completed DOTS therapy on 2 occasions.
Okay, great.
Okay. Is Dr. George there? Has he joined? Yeah. He's joining in. Okay. Okay. Fair enough. So when he joins in, we'll ask him again. Okay. So one thing is, can I ask any of the students, what is the flow of your questioning? You have, like Dr. Mehul was saying, you started off by saying on and off fever and then cough and then suddenly jump to back pain and hip pain. What is the logic in that?
Actually, it was a consensus decision.
Yeah, that's why I'm asking. What is the consensus?
So basically, the patient has. So later on, we come to know that there is a lesion in the lung, but the patient has a history of TB. So we just wanted to rule out any involvement of the bone by either any malignant lesion or TB.
So disseminated TB. You are basically looking for in terms of disseminated TB.
Yeah.
Okay. So just a quick thing. Again, these are all things which I think at level of oncology thing, we are not going to go too much into the history and ask 10 questions on it. But one thing which generally people do ask along with pulmonary TB when you're dealing with chronic fever and cough is going to be history of occupational exposures, history of any such infections, because ultimately you're dealing with infection and malignancy. I think that's the one thing which I think you have not really covered. Otherwise, whatever you have said in the history, by and large, seems to be okay. Like you said, there is more cancer-directed history that you should ask, which you have done that back pain and hip pain. Typically, we do also ask in that same scenario when you're asking cancer-directed history of any CNS symptoms or any headache or things like that. So that's one more thing which is generally covered in a history presentation. So I think that's kind of okay. Dr. Govind Babu sir, anything from your side? It's okay. I think history-wise, this is fine. Right. Let's go on to the next part. That is the examination part. So who's doing that part? Atul or Prashant, you're doing? It's a consensus, so any of you can do. All of you will be asked questions. Yeah.
So on examination, we performance status, EPA was counted 1. Effort tolerance was 2. She was able to climb 2 flights of stairs with no and on physical examination there was no enlarged supraclavicular or cervical lymph nodes. On the respiratory system examination, the airway was bilaterally full and there was no added sounds.
Okay. No, next slide is the investigation. So investigations we'll do later. So on the examination findings, first let's go one by one. So again, Dr. Mehul, starting with you. Examination wise, again, there's not a medicine exam where we go in much more depth, but still, anything that has been missed or anything which you feel should be covered.
I think in oncology, many times we look for a dilated vein to origin score, and if there is any SVC symptom.
Okay. Were there no contributory findings at all? I mean, there's a lung mass. I have seen your investigation report. So there's absolutely nothing in the thing. What else would you look for in a respiratory system? Like he has asked for the veins. So my question to you, what would you look for in a respiratory system examination in lung cancer? Assuming this is lung cancer.
So symmetry, threshold symmetry, the air entry, also whether there was any clubbing.
Yes, so that has not come.
Yes, clubbing, and also
Pallor along with that as a general thing which you need to look for. Yeah, cyanosis. Okay. Anything else that you would want? Yes, doctor.
So, would want to auscultate the lung.
So that he has mentioned, there's nothing auscultatable.
Yeah. Then we could insight if there is any tenderness as a patient has over the chest wall, if there is pain due to the skin. Any pain in the shoulder, if it is referred pain because of any brachial plexus of the teeth.
So referred pain is not something that you get on examination. There's an examination finding, right? So examination findings, if at all you are assuming a brachial plexus, what you're supposed to look for is either wasting of muscles, or else if it's a SVC, then look for dilated veins or any swelling. Those are the things that you would be looking for. So
one more thing. If you're suspecting a lung cancer, also look out for effusion findings. Patient may come with effusion.
Yes, so dullness.
More than the SVC, or we commonly see effusions coming. So any
That's why I
finding
mentioned
of
auscultation.
movement, tracheal deviation, all those things would come, which you can just see on in one go and have a look.
So Dr. Atul, medicine. This is medicine, hardcore medicine. Go back 3 years, which all of us have gone through.
Only medicine questions.
Yeah, ultimately the examination is in medicine.
What will you look for? I mean, in a lung mass, if it's coming, patient has come with fever and cough, nothing else. You don't know whether it's cancer or TB or maybe it's just an ABP or asthmatic or anything. I mean, so I said I gave out one answer: effusion. Anything else you would look out for? If not, we'll go ahead. No.
So again, we don't go in the same depth as a medicine exam probably, but there are certain basic things you need to cover. Now, in general, when we, at least this is 10 years back, so for me, it's been a long time, but in general, when you present, the main system that is involved is the respiratory system. You need to look for basic things, and just saying no contributory findings is kind of a bit of a red flag to all examiners that, don't say no contributory. You can just say air entry was equal. There was no tracheal deviation. There was no evidence of effusion. There were no bronchial breath sounds. These are the basic things you're looking for. Consolidation is what you're looking for. Then focused examination. We don't expect in a DM level entrance exam or an oncology exam to do a full system examination of the abdomen, CNS and all, but there should be some focused examination findings present. Now you spoke about no back pain, hip pain. You should look for any tenderness. Spinal tenderness is something that you need to look for. Grossly, are there any cranial nerve deficits? Again, full neuro examination not needed, but at least the eye movements are normal or not. At least the gross neurological examination is normal or not, whether the power is okay or not. These are things which you need to mention in your thing. So again, rather than going the full stepwise, what we would normally suggest is asking them, saying that this is the examination on the respiratory system because we suspect this, and then focused examination for any tumor related symptoms. That's how you break down and present. And once you say that, the examiner understands that this is what you're looking for. And even in the clinic, you're going to look for these things, right? We don't just rely on a PET CT scan. We need to ask clinically the patient, you have pain, where is the pain, what is happening? You look for clinical examination as well in the clinic, not just on this thing. So, sir, Dr. Sanjay Sharma, sir? Sorry. Yeah. So any discussion, sir? We are having basically discussion on the students. They have presented a case, which is just a couple of slides. a 65-year-old lady, on and off fever with cough, some negative history, some comorbids of only pulmonary TB twice, and then COVID vaccinated. That's something new which we have all started doing, I guess. And this is the examination finding. So anything from the exam point of view which we can ask the students.
Hi. Any other associated comorbidities, diabetes, blood pressure?
Sir,
cardiac
twice
issues?
diabetes, 2 times diabetes, once 25 years back and once 6 years back.
And no cardiac comorbidities, any blood
Right.
thinners?
No, sir.
Nothing. And I asked a very relevant question before we come to the brass tacks. Can she climb one floor? I'm not talking of another test that we are discussing about. My OPD question sent to the patient, can she climb one floor? That I asked. That's a crude method, but I'll come to the final one later on.
Yes, sir.
She can.
Yes.
All right. Okay.
Anything else that you would like to ask in the examination and the findings, sir? Or we'll go ahead with the...
That she has mentioned already.
He has mentioned in the examination, actually. So I also agree, this is not the place to put it. Effort tolerance, you don't, in the clinic on examination, you won't ask the patient to walk out and up and down 2 stairs. So we don't. You do it, you ask them questions.
I normally ask, but it is really what is, as I said, that's my personal view, but that theoretically, if you mention that what is there and if there is nothing else, then I think you have done the job. That's
Hi,
all.
this is George. I have a question. Is it possible?
Dr. George.
Yeah, hi. I think it's extremely important to ask for a history of any previous imaging or any chest-related complaint, and to get the imaging in hand before you go on to image this patient. So ask for any history of any previous lung event or a history of any imaging finding.
So again, imaging findings and any history of any lung surgery, any lung treatment done before. So like somebody said, your TB treatment actually is very, very inadequate. Just saying that taken treatment is not really sufficient. You should also say whether it is complete or incomplete. Again, these are basic medicine things that you follow. So, when you do an exam, at least for the exam purposes, remember that you cannot forget everything that you have learned in medicine and then just come and say, based on the PET scan. That's not what an examination is going to be about. So Dr. Govind Babu sir, you're an examiner frequently. So I think these are the basic things you look for. You're not going to go into depth and each and every word, but these are the basic things you look for, I guess.
Absolutely.
You first must remember that you're taking your final MBBS exam. So everything starts from there. Otherwise, you can't go ahead.
Okay. So the 2 surgical students have also joined us. So you guys were involved in making the slides, right? Okay. So you know the history and all. Very good. So we can ask you questions. So
You can drink water.
So this is the basic idea. You have to ask, you cannot change the full approach just because now it is a higher exam. And the idea of your first 5 minutes of discussion in the exam is to get that 5 minutes over with. If you get stuck here and people start asking you these questions, you'll never go to your EGFR and your monoclonal antibody. You're going to be stuck in your history and examination, which is not where you want to be. Right? I think that's the most important lesson I can give. Sir, Dr. Sanjay, any specific questions to ask to the surgical, in the surgical DM or surgical DNB MCH exams?
No, I mean, now, of course, this is a clinical finding. Now, obviously, what will you do for the patient? What investigation will you do?
Okay, so that will be the next step. Very good. So again, as a rule in exams, you will be asked to summarize. It may even happen that they may say, okay, don't give the full thing, just make a summary. That slide is not there. So can someone do the honor of doing a summary of it, which includes everything important and relevant? That's an art, by the way. Summarizing in 2 lines or 3 lines is an art which people have to learn. Who wants to take up the challenge? Yes. Go ahead. Summarize. Summary till now. What has happened and what is the 2 or 3 line summary for the patient?
Yeah, the patient which we are discussing here is a 67-year-old lady from urban place and known hypertensive. She has recovered from TB and she has had a relapse of TB in the past. Now she has presented with cough with expectoration and on and off fever for the duration, I think. And
okay, go ahead.
For the past 3 months and 3.
That's okay. 3 months.
3 months.
Yeah.
She is otherwise in ECOG performance status 1 with a good effort tolerance, and is her general and systemic examination otherwise unremarkable.
Okay. So again, the thing is, a summary means a summary. You cannot tell a full thing again in a summary. It has to be 2-line summary. Anyone else wants to try?
Because sometimes the examiners are in tear hurry because of the shortage of time. So they are not interested in what is negative, this is not there, that is not there. Positive, relevant history. And then when examiners also is a positive, relevant examination. That's it.
So,
Yes.
She's 65-year-old hypertensive female with a history of treated tuberculosis, presented with the complaint of the cough with the expectoration and the fever on and off.
Finish then. You should include the examination as the next slide. You have to tell the examination also in part of your summary.
Vamshi, one thing I just want to talk is the expectoration. I think they should talk about what type of sputum was there.
Yes,
I think
that
those
was not
things
being
are
presented.
important.
See, again, all these are things which need to be asked, and examination is important. At the oncology level, at the exam, you will be asked these questions, and you better answer them, because then you move on to the next section, or you're going to be stuck in this part, which will be of no point to anybody. This is not what examiners want to ask. Examiners also want to go ahead and ask you the next step. So don't get stuck here.
That's why Vamshi was saying that nowadays we are not interested in history. Short summary, because as you said rightly, if you go to your questionnaires and completion of the treatment process, which probably is most important, if it doesn't reach and you have a fixed time, then you are losing out.
See, essentially, I'll tell you what examiners want to know is, you know what you're asking, and you are not a menace to society once you pass out. That's the general purpose of an exam. Everyone knows you have worked for 3 years. Everyone knows that you know the subject, you will know, but you should not be a menace to society when you pass out. I mean, that's the broad general aspect. So be short, be crisp. Again, do a practice of this between yourselves. So 65-year-old lady, known hypertensive with past history of tuberculosis, now has come with on-off fever for 3 months with cough and expectoration without any localizing symptoms. On examination, there are no signs and symptoms that can localize to a particular segment of lung or any particular pathology. 2 lines you mentioned that. I think most people will be happy that you have answered everything and covered everything. So that comes out of practice. It will not come out of, just thinking on the day of the exam. Just practice this among yourselves and it's more than enough. Right. So next question will be, how will you investigate the patient? That's how the next question.
How do you proceed? Now, what do you do to the patient?
What will you do? That will be the next question that comes.
If the patient is in OPD with you, what do you do?
Correct. So this should not be purely in the OPD alone. Since it's an exam, you have to go systematically. Okay. So just don't say, I'll write a PET scan and call back the patient. That's not what is done.
What I meant is
evaluation of the patient.
How do you treat such patients?
Yeah.
So the same thing when you are asked in the OPD, you are when you take your class in the OPD itself, it's the asked us, how do you proceed? Now the patient is in front of you.
So what next? So let's start from this end this time. I'll put everybody on the spot since all of you are on stage. Yes. What will you do next?
Since we don't have, based on examination, we don't have any localizing person with known past history of TB, we'll still get a chest X-ray and the sputum tested for her.
So you'll get a chest X-ray and a sputum for AFB. That's it, or anything else you want to do?
And then I'll proceed further from there.
So first and only investigation will be chest X-ray and sputum AFB. Okay, fair enough. Next, don't listen to him. We want your answer as a full. Supposing you have not heard his answer, I'm just asking you, what will you do with this patient?
Since she is a lady with past history of tuberculosis and there was a past history of relapse of the TB also, the first thing I would like to rule out is tuberculosis. So I'll send a sputum for AFB and gene expert and take a chest X-ray. This will be the
sputum for gene expert.
Sputum for AFB.
Mehul, you want to comment on that, or shall we leave that for now?
Sputum for
AFB.
AFB.
Leave it for now. Okay. Right. Next, Dr. Prashant. Again, forget their answers. This patient has come to you first and the examiner is asking you, what next? What will you like to do?
So I would like to get the baseline blood investigations done.
Okay.
And since it's a past history of tuberculosis, get a AFP, sputum for AFP, and also get a chest X-ray.
Okay. Next. I'm just asking everybody so that everybody gets a chance to present, and then we'll tell you what other things which at least strike out to me, and then the judges can also say.
So because this can be just another case of lower respiratory tract infection also, so we would want to do regular blood investigations, including a CBC at the very least, and a chest X-ray for the time being, along with sputum evaluation for AFB as well as regular culture sensitivity for any other hormones.
Dr. Atul?
Similarly, sir.
No, I just said you should not say similar. Okay. See, the idea is, first things, when somebody asks you what do you want to do, you tell what you want to do. Don't need to explain. If you say that I want to do an X-ray and super for FB, all examiners understand perfectly well why you want to do it, right? You don't need to give an explanation in the exam that because patient had TB, I'm going to do this, right? That is number one. Number two, anyone from the judges panel, sir, can just pass your comment or ask what else you want to do, sir.
What else? What do you see in CBC?
What do you see in the CBC?
So we want to look for the WBC, TLC, the TLC, ANC counts, whether they're raised or not. And apart from that, so that would give an indication of whether the patient has any active infection.
Anything else which may not be very relevant nowadays, but definitely ask in an exam. If I may be an internal, I may not be able to protect you. Tell us.
Not specific to it, but ESR can be raised in case of tuberculosis.
So, yes, Dr.
If
Mehul.
the patient has been suffering from fever and cough recurrently, there will be evidence of anemia also. Look out for those subtle signs. And what I do in my OPD, I'll tell you, I also send a creat because if the X-ray is showing something, I would probably get a CT done with the background. So I will at least get a creat done baseline.
Practically speaking, you need a creat to do a CT scan also for the practical aspect.
Fair enough. And I will grant them if there is something relevant on the X-ray, I would go ahead and do a CT scan. That's okay.
Yeah.
You said what is initial? Initial is fine. If there is something else, something complex in the scene or very abnormal thing is there, you can say that I would simultaneously do a CT scan also.
Dr. Sagar, you're nothing. Dr. Govind Babu, sir? Dr. George, anything else that you would want to ask at this point, or this the answers that has been given?
Yeah, the answers are fine. I think this is okay.
So again, this is what we used to do in our DM. What we practiced was, rather than breaking up and saying I'll do CBP, creatinine, or the word routine baseline investigation, that's kind of sets off a ring, I think, for all examiners. When you hear that word routine examination, there's nothing routine examination. One way of doing it is to break your investigations. You say investigations to confirm the diagnosis, investigations for staging the diagnosis, staging if it turns out to be a malignancy or if it's indicative of malignancy, and then investigations to see the baseline status of the patient. So that's a simple one. When you tell this to an exam that I want to do investigations for this, investigation for this, and investigation, nobody's going to ask you, okay. And the third thing, nobody will ask you only, okay, baseline investigations, everybody understands. So again, be systematic and then approach one by one. Okay, so that's the way you should approach for all students. It's always good to approach in a systematic way. And when you do that, examiner also knows that you know what you're doing and this is what you're going to follow, right? So first thing, investigations, like you have advised, a chest X-ray and a sputum. I think, is that okay for all the examiners? Is that fine? Very good. So this is the baseline investigation. Laboratory values, which you have written, are normal. Again, we will not get into what normal values mean. Instead of a chest X-ray, which all of you said, actually a NCCT chest was done. So I'm assuming the X-ray was normal, or did the X-ray show some opacity in the lung? That's what you wanted to say.
So actually we don't, so when the patient came to us,
with a CT scan, right.
But we
Fair enough. So the CT scan in this patient showed a right lower lobe 5 centimeter SOL in the periphery with upper lobe bronchiectatic changes and small mediastinal nodes. So what investigation next? What would you do next after this CT scan? Anyone can go ahead. So surgeons can start. Let's leave it, since you are sitting next to me. I think you are the...
I would like to see the CT images.
You
think
have
it's
not
there.
given... Yes, these are your CT images.
This CT shows an axial cuts of lung window with limited cuts showing a peripheral solid lesion in the right lower lobe with some fibrotic changes partly seen in the upper lobe. There are no other gross
in the
right upper. There's some.
Okay, so lower cuts of the right upper lobe and the right lower lobe.
Lower
Okay,
lobe,
fine.
yeah. It's only limited
upper
cuts
part of the lower lobe and lower part of the right. Okay. Okay.
So these looks fairly peripheral. So I would like to further investigate, and it's a suspicious appearing tumor. So I would try doing a bronchoscopy on the patient to see.
Okay.
So it's fairly peripheral. I don't expect, but still I would like to look at the bronchoscopy findings.
Okay. Dr. Mehul, at this point.
Bronchoscopy, anything else you would ask from a patient? At least basic. I think Dr. George actually mentioned it, but you saw this patient had come with a CT scan and probably an X-ray showing a similar finding. Any other thing you would ask from a patient? This is a practical thing. So again, an OPD patient has come with a scan. Any other thing you would ask?
Anybody can take this.
Patient had tuberculosis in the past. Probably some X-ray was done in the past. So always ask for an old X-ray to compare.
Right. Dr. Govind Babu, sir, Dr. Sanjay, sir, anything else you want to ask based on this, or is this the sequence we will go with? NCCT first and then go on that. Okay. Dr. George, any further question on this? Is the plan okay? Bronchoscopy?
Yeah, so there are two questions which need to be answered in this. I would not go for an NCCT because if you're looking for a pathology, I would ask for a contrast enhanced scan for sure, because you can assess the mediastinum at the same time. This is, I wouldn't say it's centrally, it's a peripherally located lesion. So the bronchoscopy helps in staging, but I don't think can achieve a diagnosis. The patient also has a right middle lobe, post-infective or chronic infective changes. A bronchoscopy would be valid in collecting sputum or cultures from there. But this patient will probably require a CT-guided biopsy, and that's the direction I would want the student to head in.
Dr. Bhavesh, sir, anything you want to ask at this point? Any question, anything that has been missed or any the sequence? Is this okay?
Yeah, okay.
Okay, great. So next step would be what would be the next step? You have said bronchoscopy. Does everybody concur on the stage?
Yes, bronchoscopy with ball fluid for
bronchoscopy with ball fluid. Okay. Everybody? Yeah.
CT guided biopsy.
You would want to do a CT guided biopsy, like Dr. George was saying. Okay. So, Dr. Sanjay, Dr. Govind, sir, what do you think? Should we advise, as in the exam pattern, should you first do for bronch or should you do a CT guided biopsy or do both?
I do both.
Practically,
actually,
I think
I normally do it to save time because the biopsy takes time. So I get the CT guided done immediately, and then obviously, as George mentioned, I would rather look at the mediastinum, which is the most important thing for me. The other windows that I would like to see the mediastinum, and I think that is also relevant vis-a-vis in terms of the nodes, vis-a-vis in terms of other things that you can see, anything else. And then go ahead and do the bronchoscopy just to see why and what effects of tuberculosis is involved. Otherwise, if the lesion is normal and the normal trachea bronchial tree, trust me, I do bronchoscopy only on the table. I don't do it. And I'm not saying you should say that, but for me, more important is the biopsy. And of course, now in this case, certainly bronchoscopy.
Dr. Bhavesh, sir, yes, Dr.
Yeah, Vamshi, because she's had 2 episodes of tuberculosis, we should try and rule out. So I think bronchoscopy also is definitely. Yeah.
So, Dr. Govind, is there anything like a fixed pattern that in the exam you're supposed to say this followed by this, or depends on the case?
I think it goes with the patient, with the history and what you find. So, there's no set pattern as such.
So that's something for you. So you can always say this is what we want to do one by one, and you can justify each time somebody asks. But again, the aim is to move beyond this part, sir.
That's okay. As I said, in this case, bronchoscopy must.
Okay. So I think in this, please go ahead. Yeah. I am not able to find it. That's not opening. This is the CT. No, this is no. You have just mentioned it. Okay. This is the finding of the bronchoscopy. So no intraluminal tumor, TBNA suspicious of adenosis. This is a radial TBNA, I'm guessing, because it's a very far away. Done. Okay.
The slide
and BAL shows MTB detected very low, gene expert negative, MGIT culture negative, started on ATT. Okay.
BAL MTB detected very low would be gene expert report, right?
I'm assuming.
Yeah, that's how it is reported.
So actually, see, if this has been started on ATT, then this should have come in your history. So this is something which somebody asked also among the examiners, that was the patient started on ATT before they came to you? That should have come in your history.
So actually the patient started on anti-AKT after these investigations were done.
So this is exactly what the examiners were saying. You should give a history of, see, you don't need to tell this was happened. What you can say is in the exam, you're going to be given a patient, right? So you have to tell the patient underwent tests outside and was restarted on ATT or was started on some medicine which was told to be ATT. In the middle of the history, suddenly, and now you're saying that ATT was already started. I don't know, Dr. Govind, what do you think? Should that come as part of history or should that be told later? Because in the exam, you won't be given all this, right? You'll be given only a patient. So if you have that history of ATT starting, please mention it in your history. Okay, that should form a part of history. Okay, so that's the bronchoscopy. Then this thing. So the biopsy has come as adenocarcinoma of the lung, IHC positive for TTF1, negative for P40. So judges, what questions should we ask at this point? Again, that bottom part, I think the driver mutation status we'll ask later, but till this point.
At the moment. And tell me in a detail, what is the size of the lesion on the CT scan? That is one. And what about the mediastinal node seen on the CT scan?
Anyone can take it. Yeah.
That is necessary. Am I right?
Yes, sir.
Okay.
So I think it's around 4.5 centimeters in the largest dimension in the CT scan. And there were hilar nodes that were mentioned, which were subcentimeter.
And mediastinum, be clear.
So mediastinum, because as of now it's an NCCT, they've not really commented.
Okay. But that is necessary to know.
So what next would you do? So CT guided biopsy has shown as an adenocarcinoma. What will be your next step? I think that's the next question, right? All the examiners are, what do you think should be the next question at this point? What is next step? Yeah.
At this point, we'll have to do a staging investigation.
You would want to do a staging investigation. Okay.
PET CCT for adenocarcinoma.
Okay. Does everybody agree with
that? If PET CCT is non-metastatic, I would like to proceed with the MRI brain also. The next step, contrast enhanced MRI brain.
Okay, so your answer will be, I'll do a PET CT scan to complete staging, and if it is non-metastatic, go for a MRI brain. Is that your answer? Okay.
A PET CT with the MRI brain contrast.
PET CT scan whole body. Okay.
Yeah.
Other guys, everyone, you just tell what your next step is going to be at this point in the question in the exam. What will be your next step?
I would like to get a PET CT.
PET CT scan. Okay. PET CT scan. Everybody wants to do. So, Dr. Govinda, in the exam, this is okay to say just a PET CT, or are we particular nowadays in saying FDG PET or things like that? It's not a big deal.
No, as he rightly mentioned, young man, that if there is no other metastatic disease, I will definitely also do MRI of the brain.
Fair enough.
Because then the intent of treatment changes.
Yeah, Vamshi, now that you asked, we are using newer isotopes now rather than just the rotate flow oxide glucose. So those are more sensitive. They can pick up intracranial mets as well. And for those, you don't need to actually have blood sugars under control. So that's what we are doing at our center. So that is one thing. I mean, you don't have to really mention that, but if you mention it, you get brownie points for that.
I actually, Dr. Govinda, I would say that it's best to stick to the best guidelines.
I totally agree with you, Judge. But this is just if somebody is aware and they want to mention it, that's okay. If you are not mentioned it, you won't lose anything on that.
Yeah.
Okay. So what next would be the next question which people will ask. So what next? You wanted a PET CT scan. This is the PET CT scan report. Again, you have given the images as well. So this is the image and this is the report. So FDG avid fissural based soft tissue lesion. I am not sure the videos are not opening. You guys have embedded it, but they are not opening. This is again not opening any of the videos. I've tried the other videos as well for some reason. I think now. No, not opening. Right. So this is the report, FDG based pleural, FDG avid fissural based soft tissue mass, lower lobe of right lung, 3.9 into 3.4 into 4.3 centimeter SUV, and low grade FDG uptake in bilateral hilar nodes, no other FDG avid mediastinal nodes, and MRI brain, no neuroparenchymal metastasis. Dr. Sanjay sir, next question.
What do you do now? You have a non-metastatic lesion. What will be the stage as per you in this?
So TNM staging will be CT2A N1 M0.
Okay. So what do you propose? What else you like to know?
So N1 you said?
You said hilar node, that's why.
That is an
no, because if you're going by this report, it says bilateral hilar nodes. That's why I'm asking you.
See the node anyway.
Okay.
Yeah. Preferably on the image.
Okay.
So
this call is now being recorded.
As hilar node,
Hello? Sir.
So I would like to take a call. Maybe it's an N0 or N1. CT2.
Okay, that's.
Okay. Next, doctor, what will be your next step after this PET scan?
Since we have established a diagnosis and in the staging,
presume hilar nodes are negative, then proceed. Because the SPV low, so go ahead. So the state theoretically is a T2 and 0 M0.
So we have established a diagnosis of adenocarcinoma of lung, and in staging we have established that the patient is non-metastatic. So next line will be the functional evaluation of the patient to look at the further line of treatment.
What do you do routinely, and what do you like to do for this patient?
So for this patient,
planning the treatment part.
For this
because
patient,
mind well, underlying disease, patient has a chronic lung problem in the past.
so a pulmonary function test, PFT, DLCO should be done for this patient. And in view of her age, I would like to also get to the 2D echo for this patient. And exercise testing in the form of a 6-minute walk test.
Dr. George, anything from your side? Would you also agree that can we ignore those hilar lymph nodes and proceed?
Yes, definitely, because the hilar lymph nodes, in my opinion, won't affect the management at this point in the choice of radical treatment. So I would go for a functional evaluation, as Dr. Sridharan said, with a PFT DLCO and the 2D echo. And the 6-minute walk test, although it's a non-stress test, it's a good indicator of how the patient's performance status is. And it's been helpful in assessment, so I would go for that. I think a closer study of the CT is required given the history of previous tuberculosis and the fibrotic changes seen in the upper lobe to decide how difficult the surgery per se is going to be.
I agree with George. I would not just, as I said, I really discount if the SU value is low previously infected, old Cox nodes around get secondarily infected. Fair enough. So now we have an N0, T2, N0, M0, and at the test.
PFT test. Okay. Before that, sir, just Dr. Naveen and Dr. Sagar, anything different that you would also want to ask in this or any other investigation, or we'll jump to the PFT?
Vamshi, if I can go first.
PFT. Okay. Dr. Govind, sir. And Dr. Bhavesh, anything different at this point, or shall we just go on?
Dr. Vamshi, can you hear me?
Okay. Great. So this is the pulmonary function test, FVC 1.42 going up to 1.48, FEV1 and predicted post-op values have been given with the reversibilities. 6-minute walk distance covered, 350 meter, 2D echo normal. Pulmonary artery pressure also has been mentioned. So these are the values that have been given to you now. So what next?
Given this FEV1 and DLCO post-operative of between 40 and 60, she is somewhere in the intermediate risk of post-pulmonary complications, and the 6-minute walk test is also 350. So I would like to get her optimized. Maybe I'll ask my chest physician colleague to see her if optimization is possible.
Okay. Next, same answer. Anything different that you want to do? Same. Sir, question back to you. So this is the answer they have given. What next?
I agree with them. What they mentioned is that, it's just a borderline case. You can say that way, just crossing the right number. So, but yes, optimize, maybe give her a little, bronchodilators or whatever you want to optimize it. And that question may still come. How do you look to do an optimization? But yes, I agree with that statement that optimize and then repeat the test done. And if it is improving further, then you are at ease rather than having a procedure which you propose to do, which I'm not going to ask right now. And then you can plan your treatment accordingly.
Dr. Mehul, anything else that you would like to ask at this point so far?
So all these are normal. When do you want to do surgery?
Yeah. Next question. Question to you. All these are normal. Assuming all these were normal, when do you want to do the surgery? Is that your question, sir?
Yes. Remember history.
Yeah. She's open Cox at least 2 weeks of AKT. She needs to continue.
Exactly.
I was going to say, when you call chest for evaluation, is not just for optimization, but also to know when can the patient be taken up for surgery.
Very good. So, Dr. George, sir, anything else you want to ask? Or any other questions that we'll need to ask at this point, or shall we proceed?
At this point, they're okay. Let them proceed.
Dr. Vamshi, can you hear me?
Yes.
Sorry. So I wanted to comment a little early. There was an issue with my audio. So something that we generally miss out during our examination of patients and in exams also is a knowledge about paraneoplastic syndromes. So both in history and examination and also in investigation, for exam purpose, at least it is important to cover those. So some specifics about that should also be addressed while you are talking about investigation. For example, you could say when you're just saying complete blood counts, you could also add serum biochemistry, including serum calcium, because you want to rule out hypercalcemia. And probably you would also would like to talk about liver function test, because I mean, now that we know there is a history of malignancy, just to rule out liver metastasis, probably it is a good idea to cover those bases also.
Baseline biochemistry to rule out hypercalcemia. Very good. So, right. So this is the chest physician opinions sought and started on tiotropium and budesonide. And post-optimization 6-minute walk test is 430 meters walk, no desaturation. That's the report. And yeah, this is the lung perfusion scan. Okay. Next step, you wanted the lung perfusion scan.
The CT scan had showed that it was mentioned in PET that the upper lobe is bronchiectasis, it's fibrosed, and there was traction bronchiectasis. There was very minimal volume left. So that's why since she had borderline fitness, we had gone ahead with the perfusion scan.
Okay. Dr. Sanjay, anything to be asked in this? These are the reports, right to left 40 to 60, upper, middle and lower, and the absolute values are given like this.
I think so, right? So what do you propose?
What would you like to do? By the way, the radiation and medical guys also will be asked these questions. Okay, you're supposed to know this. Don't assume that the answer cannot be, I'll send it to my surgical colleague and leave it.
I can add one googly to that, but I didn't want to do that. Go ahead.
So please go ahead and add. We have 15 minutes.
Go ahead. Yes, please. Patient in front of you. Localized disease or local, question mark, local regional disease. At the moment, you're not discounting Highland nodes. And you have fairly reasonably moderate pulmonary functions. Good, in spite of all those Cox lungs and all, they're mentioning about the value of the lobes that you're going to take it out. So what lobe are you going to remove?
So in this patient, the disease is in the right lower lobe, which is pretty much the most functional lobe on the right side. So if we are planning for a right lower lobectomy for this patient, it would essentially mean that we will be knocking off 1/3 of the pulmonary function for this patient, which she won't be fit to, a borderline fitness lady. So at this point of time, I think I would like to go ahead with a non-surgical option for this patient after a mediastinal staging.
Why is that non-surgical?
Stereotactic. If the mediastinal staging comes as node negative, then we'll be planning for stereotactic RT, SBRT for this.
Dr. George, anything else on this you want to add, or on the surgical aspect? Non-surgical, they have said it's surgically inoperable. I mean, medically inoperable for a surgery.
Medical not fit for.
Not fit. Okay.
Yeah, so I wouldn't say it's totally unfit, but I would say it's extremely high risk. Is the way I put it. So it would need this is not a decision which can be taken by the surgeon alone, and given by the size 3.9 centimeters peripheral, probably amenable to SBRT also. This is probably something I would engage in a conversation with the patient and the radiation oncologist and take a proper. It's an MDT decision, not something that the surgeon alone can take. That's
what is the largest tumor you will consider? The 3 point, had it been 5.1 centimeters, what do you do then? You will consider for radiotherapy, SBRT, or you can do something different?
I will bring it to my tumor board.
Why is the cutoff of 5 centimeter, not 5.1, 5.5? And what's the problem? If you are comfortable treating 5 centimeter, what is the problem of treating 5.5 centimeter with SBRT? Question to my radiation oncology colleague.
So the chances of having mediastinal nodes, occur mediastinal nodes is higher when you go above 5 centimeters. Is why it is generally not advised, but we can do a thorough evaluation of the mediastinal, and if it is node negative, SBRT
But in this particular case, we are not thinking about any mediastinal node. We have already discounted. There are no mediastinal nodes. We are focusing primarily on the size of the lesion. Why 5 centimeters?
So if the question is assuming that this patient instead of 3 had 5 and mediastinal nodes were still negative, then what would you? I think that's the question you're asking.
Sir, for SBRT, cutoff is 5 centimeter. If it is more than 5 centimeter, then why not SBRT? It's like basic question what we ask. See, as the size of the lesion goes bigger, the chances of toxicities will get higher. So that's why the basic principle of SBRT is delivering the higher doses of radiotherapy to the smaller lesion. So as the lesion will go higher, the chances of toxicity goes higher. So that's why the cutoff is somewhere around 5.
Yeah.
Keep 5.5 का नहीं कर सकते ऐसा नहीं है. But the problem is then the chances of toxicities will be very, very high. So that's why we have kept the cutoff.
And anyway, her upper lobe is anyway gone. He'll find it very difficult to save that lung for which you are not operating.
So you said in your thing that I will do mediastinal staging and send for radiation. Was that just like you said it, or because you said that? Did you mean for this case, or in general you were saying?
In general, I mean. In general.
Okay, because I think that's what we established, that in this case we don't need to do, and that's why I heard. Okay, fair enough. Right. So
Can I ask one more question?
Yes, please go ahead.
The same question, but only if the histology was small cell lung cancer. Will anything change from the point of view of SBRT, or you want to add anything with SBRT?
If we are not considering SBRT, then we will.
No. We are considering SBRT. The case is similar. The only change which has changed in the case is the histology is small cell. Prophylactic granularity.
So I think at this point, radiation, any more questions that you would like to ask? Done. Okay. Dr. Govind Babu sir, Dr. Bhavesh sir, anything else that we want to get into this point? Anyone wants to comment on this thing which has been done already? The biopsy?
I have a question for Dr. Sridharan actually. He said that he wouldn't do an EBUS or an invasive staging on this patient. I have a question. I'm going to give a hypothetical scenario. This patient has got hilar lymph nodes with an uptake of 6.86. It's a case which can be treated with SBRT, but if you do an EBUS and find any of the nodes positive in the hilum or in the mediastinum, is it a case for SBRT, or is that something which you would consider?
If there is a nodal disease, we can and the patient has already received SBRT, we can follow. I mean, we can give adjuvant chemo for this patient.
No. So the question he's asking, if you had a mediastinal node which has come positive, you would give SBRT to the lung and then give chemotherapy.
It is now T2 and 1.
T2 and 1.
No,
why SBRT?
The doctor.
Sorry. Go ahead.
The question to Dr. Sridharan is, he said that probably he wouldn't do EBUS on this patient.
Yes,
I think that's what. Yeah. So my thing is, on the CT scan, the uptake of the primary is 10, the hilar lymph node is 6.86. We are assuming it's negative when we are proceeding with SBRT because they wouldn't radiate that area. You have an option of doing an EBUS for the mediastinal staging, as well as we can sometimes access the hilar nodes as well. Would it make an impact on the treatment?
Yes.
Yes, Dr. Atul, go ahead.
So, if the hilar nodes are positive, first thing we will not able to give the SBRT. Then we have to plan definitive CTRT if the hilar nodes are positive.
So, Dr. Prashant, Dr. Unmesh, radiation. This is a radiation question. Supposing Dr. George is asking, I will do the hilar nodes and it may come positive. Would you still do SBRT? How would it change your plan?
If any of nodes do come positive, then we would lean more towards doing chemo radiation.
Louder. You can be louder. It's okay.
We would do chemo radiation. We wouldn't do SBRT because in SBRT you cannot treat the nodes.
Okay. So, Dr. Unmesh, Dr. Sagar, anything else? Follow-up questions on this?
Thank you.
Okay.
Can I ask a question to the radiation oncology colleagues? Prashant and Unmesh. So just taking the hypothetical situation that Dr. George had presented in front of you. So you have a primary and you also have a suspicious, probably proven hilar lymph node. So what stops you from giving SBRT to the primary and also SBRT or a hypofractionated RT to the lymph node? Why can't you consider that?
Dr. Unmesh and Dr. Prashant, what stops you from giving SBRT to the nodes?
And give chemotherapy adjuvantly. Yeah.
This is a periphery located tumor, and since node is positive, encompassing both.
Correct. See, even when you're doing definitive radiation, you are only going to target the involved node. You're not going to do elective lymph nodes, isn't it? So here we have a patient who has a primary and a hilar lymph node. So what you do in definitive IT is giving 60 grain 30 fractions with concurrent chemotherapy. So instead of that, can't you just give 60 grain 5 fractions to the primary and probably give a different dose fraction to the hilar lymph node?
The volume
Because
of the
ultimately
lung,
that is what you're treating. You're treating both the gross disease.
so the volume of the lung receiving radiation will be higher, and giving hyperfractionated RT in this situation might lead to more toxicities.
Hilar node in any case would be kind of ultracentral structures. So that would lead to more toxicity combined with the increased volume. The patient would be safer treated with protracted radiation, with chemotherapy.
Yeah, so you partially right in the sense that when you're treating the hilar lymph node based on its location, I mean, if there is mediastinal lymph node also, so they are going to be little central or ultracentral in location. So the dose fractionation has to be different. They might be associated with more toxicity. And also we do understand that since patient has a node positive disease, there is always a risk of systemic failure. So you would want to give chemotherapy as early as possible. So we generally prefer to do it along with radiation. So it is not such a bad idea that you can't do SBRT for both the lesions. It's just that it is unexplored and it is a little unconventional to do that. And we stick to doing definite, conventional radiation for most of these patients.
I think if I can ask, my conclusion, this is not yet a standard of care that you would do it, Dr. Sagar. Would you do it as a standard of care? I think as examiners,
locally advanced cases.
So I think in exam, let's not go into areas which are not standard of care unless you're really prodded into it. So that brings me to the next thing, Dr. Atul. Would you send driver mutation studies for a T2N0 which is being treated with SBRT? This case T2N0, would you send driver mutation studies for all such patients?
So we will send for EGFR and the PDL1 because there are data for the adjuvant TKI treated with the definitive treatment and followed by chemotherapy indicated. So
Dr. Govind Babu, you'd like to take that?
Yeah, actually, if you have decided to give CTRT for this patient, I would not do that.
No, sorry, SBI.
Yeah, okay, SBRT. So other thing that is coming up is a BRAF mutation. It is shown that in the earlier stages, the BRAF mutation is different. In advanced stages, it is different. But I mean, if you don't answer this, that's okay. Those are very new coming things that are happening, and we don't know what bearing it is going to happen. It will have on further treatment for these patients. Yeah, if you're doing SBRT, I don't think we have any data to say that you can give adjuvant TKIs for these patients.
That's exactly why I asked, because it has been done.
Yeah.
As of now, the trials have not yet clearly said it should be done.
Exactly.
Even in fact, after CTRT, we don't know whether you should do. Only after surgery, we have that data with ADORA. We do not have the data with SBRT.
Two of you are in medical oncology, no?
Only one, sir.
Only one, okay. What about induction chemotherapy for these patients? Nodes are positive, you have a peripheral disease. Would you like to give some induction chemotherapy and then look at CTRT?
Let me make it a little bit more interesting. Operable lung cancer, neoadjuvant chemotherapy, or with large nodes, induction chemotherapy?
Yeah.
We can give the induction chemotherapy, sir, if the nodes are positive, because in the Gorda situation, the node is positive, then that time the adjuvant chemotherapy is also indicated. In the both situation, we can use the neoadjuvant chemotherapy also.
I think in the exam,
okay, let me talk about something else. No, I'm not talking about just chemotherapy. I said neoadjuvant therapy. Let's make it a little more complicated. So what are the emerging things coming out in neoadjuvant
now
therapy?
the immunotherapy checkpoint inhibitors are with the platinum doublet are also there in the neoadjuvant settings before the surgery.
Since you brought up immunotherapy with chemotherapy, what about single agent immunotherapy?
So you need to know which immunotherapy. Will you give avelumab? Will you give durvalumab? Will you give etizo? Will you give
For nivolumab, sir, we have the trials in the adjuvant settings, sir.
No, we are not talking
about
adjuvant
settings, sir.
So what are the outcome of these?
So in the neoadjuvant setting with the immunotherapy with platinum-based therapy, there are more pathological complete response and the major pathological complete response with better in comparison to the number of the surgeries done was also higher with the neoadjuvant immunotherapy, sir. And also the
Yeah, Vamshi, I think you can take it.
No, we have 1 minute left, or do we have more time? Shall we stop at 1 minute? It's up to the examiners and the examinees. If you guys are okay, we'll continue. Otherwise, we'll stop. Dr. Bhavesh, sir, anything else you want to ask on this aspect, especially the neoadjuvant chemo, the TKI adjuvant setting? Anything that you would want to ask?
Very pertinent question, that whether in an operable cancer, are you going for any neoadjuvant therapy or not? And if it is operable cancer and we are doing a real curative surgery, any role of adjuvant therapy? And the most important is the question of to a medical resident, that whether any target or driver mutations would be done on day one or on previous to any definitive therapy, because this has so many pertaining the further therapy, as well as now recently we have to ultimately conclude what should be this follow-up or surveillance of some type of operable or early lung cancer.
So we have been asked to stop. So what I'll do is I'll just request each of the judges to just give a last comment, and then I'll just wrap up in a minute. I hope that's okay. So Dr. Mehul, any last comments or any comments for the students? One by one we'll go. Yeah. Okay.
Question for my surgical colleague. If the same patient was,
I think we are done with the questions. We'll discuss the question over lunch. We'll spoil his lunch also. But if any other comments overall you want to make on for the students, or any help for the exam, something like that.
Just end with a comment that the surgical fit patient, whether should be given an option of HBRT upfront, or should be, it's an open to discussion. But the flow of the discussion was, if unfit, then only send for HBRT. So now I think it's the time we should think about to considering the operable patients also for HBRT.
Dr. Sanjay sir, anything which you want to give a comment or anything?
Yeah, I think they have done reasonably well, and I think the treatment which was suggested is probably optimum for the patient that you produced here, and I would do that. But the situation may not be like this. Usually, the surgical team who are going to keep the cases, they will not keep cases for you only for giving LGITO for that matter. So you will have to be prepared. Surgery, what type of surgery, if the pulmonary functions are borderline, would you choose a VATS or would you choose an open? That will be a scenario, and you'll have to be very certain why should you do only VATS and why should you not go do an open. But there is enough data and literature to suggest a morbidity and mortality, the open is far higher than what we do today in VATS. So that will come into the fore.
Going now, sir.
Yeah, I think as Vamshi already mentioned, you have limited period of time during this exam. So you must take those opportunity to see what you can discuss in your field more, rather than get stuck at history taking, examination, those things. Those are important. So you should not make a mistake there and get caught there and waste your time. You need to go ahead and show them what you have learned in your 3 years of your residency. So that's what is important.
Dr. Mehul?
So as a general rule in exam, if you are mentioning something new, better have a data to back it up. That's it. Probably I would not be aware of the new findings what are happening in treatment, as you said about new chemotherapies and all. But if I have data, if there's a standard of care, that should be mentioned first. And then when you're mentioning new data, you should have this study has shown or recent studies have shown. You should be able to quote the studies.
What Mehul meant is, don't put your foot in your mouth.
Yes.
That's what I was going to say.
Sir, Dr. George, any final comments?
I just finished our MCH exam of 24 candidates yesterday. So my word of advice to the candidates is that just it's best to quote what you do in your daily practice. Just forget the theory for a bit. It's best to organize your thoughts, mention what you're going to do in an algorithmic fashion, and be ready to justify any branch of the algorithm that the examiner asks a question. The important thing is the thought process is what the examiner is trying to test. Are you safe to let out? So follow an algorithm and be able to justify with reasonable evidence whatever decision you have taken.
Dr. Bhavesh, last words.
Write down everything, whatever your thought on, also on the paper. Whenever some examiner asks you some questions, and give a crisp answer. And every your answer will also have some following question also. So at least give an answer where, like one of the example you had asked that you had not mentioned the patient has started ATT. So if that's a type of thing, then it should not be like that. That suppose PET's done and you had not answered that PET scan has been done. So give a answer in a proper flow. The flow of answer or flow of scenario is also very important. And most of the examiners are also in hurry. So give a crisp answer and give a short answer, and that will lead to ultimately reach up to the target mutation, reach up to your final management. Thank you.
Dr. Naveen, any final words?
Yeah, so my advice is that you try to stay away from potential traps, steer the examiners away from those controversial stuff, stick to standard treatment guidelines and modalities. Nobody will penalize you if you don't know controversial or if you go wrong in saying controversial stuff. So stick to the standard treatment as much as possible. If somebody is asking you certain controversial questions, that means probably you're doing extremely well in your exam.
So I think my 2 cents, again, I think the most important thing is nobody is coming to an exam to fail you or to fight with you. Everyone just wants to make sure that you know the basics and the basics are done correctly. And like Dr. George said, follow an algorithm. The best way to attend an exam is to practice with each other. So in our DM, we used to do that. We used to sit at night 10 to 11 and present cases to each other and ask questions. You have a clear set of algorithm to follow. Number 2, don't get flustered. It's fine. You may not know everything on that day, and examiners know that. Like I said, examiners are not here to trip you up and make you confused. They want the basic broad guidelines which are being followed. Smaller details here and there, you can go into digressions and all, that's fine. Try to avoid those. Don't fall into pitfalls. Tell the basic things. If you don't know something, say, I don't know. That's okay, rather than digging a hole and saying wrong things. And finally, if there's a controversial topic, accept it and say, this is controversial, but this is what we are doing in our institute, or this is one of the options that can be done. This is under investigation. This is under research. Use those words so that people don't assume that you're saying something wrong. I think that's all I think I have from you. And at the end of it, I think we should give a big hand to these guys. They have come busy OPD. So I know you're not in that frame of mind of exam, but you all come and very nicely volunteered. This is just a small example. 6 months after you pass, you're going to be sitting on that side of the audience and looking at someone here. Okay, it's a very thin line between being a student and a consultant, and I think all of you are going to pass. It's just a matter of attending that day in a good frame of mind. I think that's the most important lesson all of the students should take home. When you go for the exam, be cool, practice. You're just going to tell what you have been doing over the past 3 years. No one is expecting unnecessary things. I don't think any of us remember half the clinical trial names. We know the gist, we don't remember the names also at our age, right? So I think that I will end the day, and thanks to the organizers for arranging something different in a conference. I think it's the first time I've ever done this in a conference. So thank you, everyone.